Good morning. If everybody could please take their seats and get situated, we'll go ahead and get started. Good morning. Welcome to the 11th Annual Neuropathy Action Awareness Day. We are here in LA. My name is Kathleen Creason. My professional role is Executive Director of the Osteopathic Physicians and Surgeons of California, but I also happen to be a dear friend and colleague of the person who puts this all together and is responsible for the magic that all occurs to make this happen, and that is Dominic Spadafora. Dominic. We've got a terrific turnout here in this room. I'm so glad to see everybody here. We also have more than 1,000 people online, live streaming, watching the program. So welcome to all of the people who are watching remotely. And for those who are watching remotely, we do have the agenda and materials online on the Neuropathy Action Foundation website, so you can access the materials there. And everybody here in the room has a packet in front of you. You have the biographical information of all of the speakers in the packet. So as I introduce the speakers, I'm just going to highlight some of the key facts, but if you want to learn more about them, you can access their information in the packet. I would also like to take a moment to thank very much all of the sponsors who have been so very generous to make this program happen, as well as the exhibitors that you have in the hallway and also in the back of the room. Please make sure you take the time to visit them. I've spoken with a number of them already this morning. They've got some great information. I think that could be very helpful. So please make sure when we have the breaks, you take the time to interact with them. You can get some great information. We will have a break between 11:30 and noon. We will ask that you actually leave the room so that the hotel staff can get all set for lunch. Lunch will be back here in the room. And we also have a live auction that is going to be occurring throughout the program. It will end promptly at 2:45 this afternoon. I have taken a look at the entire table, and I will say I saw Dominic's name on a lot of the items already. I've put my name on quite a few of them also, so I think he and I might have a battle, but take a look back there, and there are some really fun items that, some getaways and things like that you might be able to treat yourself or a family member to. So, with no further ado, I will go ahead and introduce our first speaker. Perry Shieh, MD, PhD, is the Associate Professor and Director of the Neuromuscular Program at the University of California, Los Angeles. Dr. Shieh attended Johns Hopkins University School of Medicine. He completed a neurology internship at Yale New Haven Hospital, and also a neurology residency at Stanford, as well as a neuromuscular disease EMG fellowship at Brigham and Women's Hospital. And probably even more importantly, I just learned that Dr. Shieh is a brand new father. He just had a baby. His wife had a baby yesterday. And he is still here to present to us. So Dr. Shieh will be presenting Neuropathy 101 Signs, Symptoms, and Causes. Dr. Shieh.
Thank you very much for that introduction. Dominic asked me to give a Neuropathy 101 talk, which is just supposed to lay the foundation, and I think that we have some really nice talks that Dr. Lewis and Dr. Ralph are going to be speaking on. I was trying not to cover and go into too much of their topics. I think what I would say is that I'm going to try to introduce kind of how a physician, a clinician, a neurologist would see neuropathy and perhaps be confused by neuropathy and how confusing it could be, and I think that would be a great segue into Dr. Lewis's talk, where he'll bring a lot of clarity to this. Okay. So let me just really start from the very beginning. What is neuropathy? And I want to really emphasize that it's a really broad term when we talk about neuropathy. And I just, the way I would like to phrase it is there's something wrong with my nerves, okay? And literally, I mean, it's hard to say much more than that when we talk about neuropathy, because there's an implication that the nerves are damaged. There's an implication perhaps that the nerves are not working, and that's not always the case. Sometimes we use the term, in cases where the nerves are actually working and so forth, and that's why I wanted to take a step back and talk about that. And so when we get to diagnosis, what are we trying to do? Well, we attach a lot of different terms here, and I'm just going to kind of throw them up here, and I'm sure you've probably heard of some of them, and perhaps a lot of them. Some of you probably have been told that you may have some of these. Some of the patients here may. Just simply neuropathy, nothing else. You have neuropathy, and that's probably something you've been told. Small fiber neuropathy, probably some of you have heard that before. Idiopathic, which is a fancy word, which many of us try not to clarify too much. The doctors sometimes use this term called distal symmetric polyneuropathy and even put a little abbreviation to it, okay, DSPN. Some of you may have been told, it's a little less common, something called mononeuritis multiplex. You may have heard of that. And these are all terms that get thrown around, and they could be a diagnosis. It could be an assumed diagnosis. It could be a presumed working diagnosis, and that's where some of the confusion comes, is that sometimes we're not quite sure. We're working our way towards understanding what it is that somebody has based on the symptoms. Okay. So let me also talk about what nerves are. So, the best way to think about it is it's like this cable, and I found this cartoon. It's a nice cartoon that shows all these, cables running in the middle of this big, thick, so literally it almost looks like a big wire that you might imagine, electrical wire. And that's a good way to think about it. And in here, let me see if I can get the pointer to work. So these little red things is the meat of the wire, and there may be some here that have insulation around them and some of them that don't. And information goes both ways, so it's like a two-way highway. There's information that's going up to the brain, and that's sensation, that's how you feel. And then there's information that's going away from the brain, commands that the brain is sending out to the rest of the body. And usually it's going out to muscles, but it could be going out to other organs as well. So it's really just a two-lane highway, so to speak, or multiple lanes, but two sides of the highway that's conveying information in both directions. So this is a cartoon. I decided to pull up what a real nerve looks like. And so this is a nerve biopsy. It's stained. And so you can see here, it doesn't look too different from what this artist has drawn out here. There are all these little red colored things. That's actually the myelin, the insulation. And there are a number of axons in there, the cables of the wire that are actually surrounded by myelin, and there are other ones which are not. So you can kind of get a little idea of what's going on here. And not to get too technical, but I just wanted to convey that these cables really are conducting electricity. They're nerve signals. And they're not electricity in the traditional sense that we think about with electrons moving down a metal wire. They're ions like sodium and potassium, which are providing that signal. It's kind of a wave that travels down from one end of the cable to the other. So this is that wave. I think part of it's getting cut off, but you can kind of see that this wave is of positives and negatives. It's kind of like literally a wave in the water. Something's kind of getting flipped around and then gets unflipped. So signal looks like that. And peripheral neurons, so these are the cells. So this is the cell in its cell body, but it reaches out with this axon, this cable, and it has the insulation here. These are the Schwann cells, which form the myelin around around the nerves, around the nerve cells, the neurons, in the peripheral nervous systems. And it conducts electrical current. The axons do. And the myelin kind of helps to make sure that that current doesn't leak out too much. Just talking about fibers and their size, we have little names for the different types of fibers. This is mostly the sensory fibers, but there are small fibers and there are large fibers. And the small fibers, the smallest ones don't have any myelin around them. Those are C fibers, and they conduct information that usually tells you about pain or heat, warmth. And then there's something that's a little bit larger, but still considered a small fiber in the big scheme of things, called an A delta. And you can see there's A delta, A beta, and A alpha. And these do have myelin around them, but they're still rather small. They're just a little bit bigger than C fibers. And then there are larger fibers, which also have myelin, A beta and A alpha fibers. So I think what you can get a better handle of is why we start using terms like small fiber neuropathy, if you've heard that term before. And you can also see that patients who have small fiber neuropathy, in our best understanding, have a lot of symptoms that are more directed towards pain. Okay? Because the modalities that are being controlled here with C fibers and A delta fibers tend to have pain associated with it. Whereas things like touch and knowing where your joints are, that tends to be over on the right-hand side. Those are the larger fibers. Looking over here at the big picture, of course, we have the brain, the spinal cord, and then all these nerves traveling out to the rest of the body. So there's information going out, motor neurons, motor portions of the nerves, as well as the sensation, where information is traveling back to the brain. Just to give you a little idea, it's the same cable that starts over here somewhere in the spinal cord and makes it all the way out to, let's say, the finger. It doesn't relay in the middle. It's one continuous cable. And likewise, going backwards as well. So there's something I was just going to mention that's called the autonomic nervous system. And there are neurons that are involved in autonomic nervous system as well. So some of you may know what this is, but basically there's a part of the way we control our bodily functions, which is not something we think about, not something we're paying attention to. So it's non-voluntary, unconscious functions. And you can start to list them out, and I think, after you see them, you'll see that they kind of make sense. Tears are a little bit involuntary. Saliva, sweating, you don't think about doing these things. Urination is kind of involuntary thing. You do purposely try to urinate and control that, but in the end, it's sort of along the same system. Bowel movements, digestion, heart rate, for instance, you don't necessarily think about speeding up your heart rate. And then there's erectile function, which can also be affected in certain kinds of neuropathy too that affect the autonomic nervous system. This is a picture that shows the autonomic nervous system, and there's the sympathetics, which are over here on the left, and the parasympathetics. And you can kind of see drawn out here some of the organs that are affected, the tear glands, the saliva glands, controlling the bowels, controlling digestion, the heart rate, and all this stuff. These are the functions that are being controlled by the autonomic nervous system. And these could potentially be affected by certain kinds of neuropathy. Are all neuropathies the same? Well, I think you guys know that they're not the same. But just to kind of illustrate different types of things that can be happening, different patients that we might be seeing as physicians, the first line is, it feels like my hands and feet are burning, but then my doctor tells me there's no evidence of nerve damage. So commonly that's something we call small fiber neuropathy. Here's another patient. One day my nerves just started degenerating slowly, and it's been the slow decline over many years. And year after year, it gets worse and worse, but it's pretty slow. So that's probably one of the more common things that we see as physicians. Seems like this disease is attacking certain nerves one at a time in little episodes. Okay. First in the hand, maybe in the left foot, then in the right foot, then the left hand, kind of in almost sort of a random fashion. And so that's sometimes what we call mononeuropathy multiplex or mononeuritis multiplex. Or the fourth one, I've always been clumsy. Never good at sports, but it seems like it's getting worse as I get older. Okay. So that's probably something that's genetic or hereditary. Yeah. Or here's the last one. I was perfectly fine one day until something just started happening to me, and it happened really quickly. Okay, and I was numb and weak all over within a matter of weeks or even days. That might be something like Guillain-Barré syndrome, or if it's a little bit slower, something like CIDP. So I kind of draw this out, the progression of neuropathy. You can see going over to the right, that's time. Okay, and let's just say you start off at 100%, it just declines slowly. That's the first pattern. Perhaps one that happens very quickly over a couple of weeks or a couple of months. Maybe one that happens somewhat slower, but still rather quickly. And so we arbitrarily designate, different time scales. Like the first one we call chronic, chronic progressive. The second one's acute. And the third one might be sort of a subacute. And these are terms that doctors like to use to describe them. And in a lot of these cases, like for instance, the second one, you might be able to treat it, like if it were Guillain-Barré, and you can facilitate its improvement, make it improve faster, and you might see a treatment resulting in a significant improvement over time. The third one, you might be able to treat as well and then see a significant improvement, perhaps even with ongoing treatment, continued preserved function. In some cases, though, the treatment is actually going to give you an improvement, going to give the patient an improvement, but it's less dramatic. And so we do see cases where it might be, let's say, an autoimmune disease, which is treatable, but perhaps has incomplete improvement. And we oftentimes see that, let's say, with vasculitis and mononeuritis multiplex. So when we're seeing patients, one of the things that we really like to consider is what is the progression of the disease? Because, comparing these three graphs, it would, lead a neurologist to consider different diagnoses. And so the story is very important. So you'll notice that, a lot of neurologists will probably spend a reasonable amount of time asking you, well, how did this begin? And then what happened? And then what happened? And then what happened? And we take a lot of notes to try to understand what was the story. How did it all evolve? And that's the history taking. Then there's the distribution. So this is a patient, and we're just coloring perhaps where all the sensory symptoms are in the hands and in the legs, and perhaps in the legs more so than in the hands. And this would be the distribution of something we call distal sensory polyneuropathy. Or it could seem like it's random, like one part of the left hand and the other part of the right hand, and one part of the right leg in this sort of seemingly random, one nerve at a time type of thing. And this is multiple mononeuropathies. So the other thing that we like to consider is the distribution. So that's number 2 here. I'm accumulating a little list of things that we like to hear, like we physicians like to hear. Let me give you an example of a patient. Joe, he's 15, comes to me because he doesn't run very well. He sprains his ankles a lot, and after we kind of look at him a little bit more, we do decide that, yeah, he probably does have a neuropathy. So that makes me think that, well, it's so early onset, we might actually think that this might be something hereditary. So the early age of onset. And what's interesting, if you take Joe a little bit further, you can say, well, this is what his feet look like, okay? And his dad has them too. And in fact, when I go over and look at the dad, I decide the dad actually has a neuropathy too, but for some reason, he's is not as aware of it as his son is. And so we see this sometimes. And then, of course, that provides additional evidence that the patient may have something that's genetic or hereditary. And sometimes the family history is actually not that obvious, like in this case, because certain patients might have it a little bit more severely than other patients. So family history is potentially helpful in helping us to characterize what this disease would be. And then there's this myelin that we talked about, the insulation around the cables, around the axons. Right? And this is a very nice dramatic picture of myelin melting away, which I think is interesting, but probably not actually what's happening. But we tend to think about myelin perhaps, at least traditionally we think about it being unpeeled, which may not actually be the case in all these patients who have myelin problems, myelin neuropathies. But loss of myelin results in impaired propagation of the signal. The signal doesn't make it down the axon as well. And usually when we do nerve conduction studies, we see that the velocities, the speeds are very slow, much slower than we're expecting. And we have numbers that we're looking for. So for instance, 50 meters per second might be a number that we're thinking is more of a normal number. And then we see patients who have 20 meters per second, and we think, this is really suspicious for something that's a myelin problem. So if we do nerve conduction studies, and we see this demyelination pattern, that could be a clue as well. Here's another patient. I'm calling him Aaron. He's 49 years old. He has burning in his feet, and when I saw him, he looked pretty normal to me. His nerve conduction studies actually turned out to be normal as well. And we did a few regular blood tests that we often do for neuropathy, and they were all normal. And we gave him a prescription for gabapentin, which he said he responded to. Perhaps not. Perhaps the symptoms didn't go away completely, but he said it helped his quality of life. And so this is sometimes what we might call small fiber neuropathy. I say that these are nerve symptoms, but perhaps without nerve damage. And we're always looking for some evidence that the nerve is actually not working on the EMG tests, on the nerve conduction tests. But if it's not damaged, then that's good news. But perhaps the nerves are somewhat irritable. And that's what gabapentin does, is it kind of calms the nerves a little bit to make the symptoms less prominent. So less irritable. And you could call that a neuropathy, but it's not nerve damage in the traditional sense. So that's why I'm saying neuropathy, you could use that term broadly to say that you're talking about something's wrong with my nerves. Let me just talk a little bit about some blood tests. This is a list of a bunch of blood tests that are commonly sent. I'm not going to go through all of these, but we often look for diabetes, vitamin B12. We're looking for autoimmune types of, problems sometimes. It could be vasculitis. It could be some of the other antibodies that we're looking for. Sometimes we're looking for toxins like heavy metals. Or if we're thinking about something that's genetic or hereditary, we might send like DNA tests. So diagnostic blood tests could be helpful. Now what I want to impress upon you here, though, is that a lot of this, for instance, the first 4 bullet points are really things that we find out from our patients by asking them, by taking a history, by looking around and observing. Okay, we haven't even drawn any blood yet. We haven't pulled out our EMG machine yet. So and it really does provide us a lot of clues, and really forms kind of the groundwork for understanding what it is that we want to check for. So sometimes it doesn't always make sense to just jump straight to doing blood tests, because the blood tests can kind of throw things out of context sometimes. So let's talk about some of these pitfalls. And this is Bill. He's a 52-year-old man who I saw last year. He was previously healthy, but 4 months before he came to see me, he noticed he was having some fatigue, and then 1 month later, he couldn't climb stairs, and eventually he couldn't stand or walk, and he came to me in a wheelchair. And actually, he had seen a couple of very reasonably good physicians who had been trying to diagnose him and told him that he may have this or that, and told him that he may have CIDP, and actually treated him, but he was not responding. And these are some of the blood tests that I sent on him. So his hemoglobin A1C was 6.0, which is borderline and suggests that he may have glucose intolerance or prediabetes. His thyroid test was also out of range. His vitamin B12 was also out of range. We did this immunofixation test, which was also abnormal. And I did a spinal tap on him, a lumbar puncture, and that was also significantly abnormal. So potentially I had about at least 5 different directions to take this patient, okay? And you can imagine that it's very easy to have a patient who has a neuropathy, as a physician, have a patient who has a neuropathy, and some blood test is going to come back positive, like the thyroid test, and I could mistakenly just say, oh, this is just a thyroid neuropathy, which honestly I'm not sure exactly what that is, okay? But somehow it gets listed among the different lab tests that we often send for neuropathy. So he ended up having something incredibly rare, which we're still actually treating him for. He has POEMS. Anybody ever heard of that? POEMS, P-O-E-M-S. Yeah, so somebody's heard of that. But anyways, there are a lot of different rare neuropathies that we see. So blood tests can be misleading, so that's pitfall number 1. Let me talk about Mark here. 62-year-old man. He couldn't walk very well. He had numbness in his feet, and his primary doctor was wondering if his neuropathy was the cause of his symptoms. Really couldn't walk, came in, and I was looking at him walk, and I could tell that, there's something very odd about the way he was walking. He was bouncing a lot. So when I saw him, I agreed that he did have a neuropathy because I did some tests on him and he had neuropathy. But based on the way he walked, I thought that he probably had a spinal cord problem. Okay. And in fact, the MRI did show that he had arthritis, which was pushing on his spinal cord. Okay. So in this case, the neuropathy, which is truly there, was the red herring. And what was really bothering him was not the neuropathy, although I'm sure it bothered him a little bit, but what was bothering him in that case actually turned out to be a spinal cord problem that he needed surgery for. So sometimes patients have a neuropathy, but they have something else too. So we have to make sure that we're looking at the big picture. And then going back to this picture, well, it provides some clues based on what you're seeing here, that there's something a little bit odd. But sometimes you might see this and say, hey, this could be a distal symmetric, symmetric polyneuropathy. And sometimes it's hard to distinguish that. But then if we go back and look at the history, and sometimes it's based on what the patients have told us, we find out that, well, actually, it started off like this, then it progressed to this, then it progressed to this, and then this, and then finally like that. All right, so that progression tells a very different story to me than, oh, it just kind of creeped up from the toes and the fingers. Toes first up, and then finally into the fingers, and kind of started creeping up closer and closer. So that makes me think of different diagnoses. So this is challenging issues or pitfall number 3. The snapshot. When we are seeing patients and when we're thinking about what you look like, that's not necessarily the whole story. We want to know the whole story. It goes back to making sure that we know the whole history. So I had this list earlier neuropathy, small fiber neuropathy, idiopathic, distal sensory polyneuropathy, and mononeuritis multiplex. And these are really, a lot of these are just descriptions because we don't always know what's causing neuropathy. We're hoping we can get a better understanding of what is causing patients to have neuropathy. And if we can identify that, perhaps we can treat it. But sometimes we're not able to. So we just give the best description that we can. This is distal symmetric polyneuropathy. This is mononeuropathy multiplex or mononeuritis multiplex. A lot of these descriptions may have a common association. Like for instance, this last one is associated with vasculitis a lot of times, but not always. And it's our goal and our job to actually try to make sure that we get the right cause whenever we can. So a lot of times the goal is to identify a cause of the neuropathy, or at least a pretty good educated guess. If not, then describe which nerves are involved and have everyone, all of our colleagues who end up seeing patients for second opinion, maybe third opinion, to weigh in on what they think might actually be a cause. So our diagnostic tools, I think I've made it pretty clear to you. We're interested in the history. We want to know the story. We want to know what you've been feeling, what you're able to do, what you're not able to do, how long this has been going on, how it happened, what has affected family history, if you've been exposed to anything, is there anybody who sometimes we think about, hopefully not being poisoned, but is there somebody who might want to poison you, those types of things. I mean, it comes up, We always want to assume that everyone's good, but, then... And that's a big portion of what we're trying to collect in terms of trying to understand what patients may have. And the exam, when we examine our patients, we're really looking at the distribution, where a lot of times we're actually just confirming what the patients have actually just told us. Well, you told us that you have foot drop, and we examine. Well, yeah, you do have foot drop, And if it doesn't match, then there's a lot more to discuss. But most of the time, if we've gotten a good history from our patients, then the exam should pretty much just confirm what we've just discussed with our patients. And then we do some additional tests, nerve conduction studies. We want to confirm if there's been nerve damage. Also want to see if there's been any change that looks like demyelination that might lead us down certain diagnoses. And blood tests really are confirmatory. And in the case of Bill that I presented earlier, you can see that the blood tests, if you just order them without any context, without knowing what the story is, you have no idea. I mean, it could really lead you in many different directions, which are the wrong directions in some of these cases. So that's why we're very careful about just not assuming that any abnormal blood test is exactly the answer. And then nerve biopsy. I mean, we really try not to do nerve biopsies too much. Nerve biopsies are something that we're taking out a nerve, and that nerve's not going to grow back. And if the nerve comes out, I would hope that nerve is pretty abnormal. And that abnormality is going to actually show what our patient has. But that's actually rather difficult in a lot of diagnoses. Usually it's most helpful if we're considering something like vasculitis or if it's amyloid. And that's because those are the diseases which tend to show something on the nerve biopsy. So I'm just going to only have a couple more slides here. Now that I've shown you how confusing it can be and how important it is for us to know what our patients are experiencing and how long and the history and everything, you can kind of appreciate, that we're really trying to solve a little bit of a mystery here, And it's not always that easy. Some patients, it's easy for us to figure it out, and there are a lot of patients where it's a little harder. And we kind of have to just put things together and hope we come up with an acceptable answer and perhaps something that will lead to some kind of treatment. And I've listed here a bunch of different things, and it's hard to create an exhaustive list, and that's why I decided I would not go through each disease one at a time and explain them. But I think you can kind of understand that, you know, we look at these diseases, we think about what the typical patient should sound like based on the history, what their exam should look like, and what are the confirmatory tests that would establish that these diagnoses are actually correct. Okay. And you know, sometimes, like I said, if you're looking at one little spot here, you'll have no idea what's going on, but then if you look at the big picture, then you'll have a better idea. And this is one where the answer is quite clear, what we're seeing. This is the number 6, unless you have some color blindness, right? This is actually a test for color blindness. So, and then there's of course this one, which is, you know, do you see the young lady with the chin, and this is her ear? She's wearing a nice little hat, or do you see the old lady with the nose and the chin and the mouth? And you can sit here and debate. You know, is it the old lady or is it the young lady? Is it this neuropathy or is it that neuropathy? And I mean, could be a good debate, and sometimes we don't know the answer. So that's the point. And so now that I've created a confusing landscape, I'm going to rely on Dr. Lewis perhaps to clarify everything there is. Thank you.